Hello, everyone. On behalf of the National Alliance for HIV Education and Workforce Development, also known as NAHUD, I would like to welcome you to our monthly webinar series and thank you for participating. Before we begin, I would like to review some housekeeping items. We invite you to use the chat to engage with your fellow attendees. Today's session is being recorded. The session recording and a PDF of the presentation slides will be added to NAHUD's website as a resource. You will receive this information in the post-webinar email that will be sent out through Zoom. You can also visit NAHU's resource page on the website to find this resource and view the past sessions. Throughout the session, please use the Q&A pod to ask your questions. The speaker will address them at the end of the presentation. If there is time and you would like to ask your question live, please raise your virtual hand and I will open the line for you to speak. Also just so you know that Ashley did add a chat waterfall in the chat, and we do ask if you can please include your name, your organization, and what level of experience that you have with injectable buprenorphine, none, some, or a lot. So NAHUD is a membership organization of 8 regional and 2 national AIDS education and training centers, also known as the AETCs. Established in 2010, NAHUD supports the AETCs, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical management for people at risk for and living with HIV. NAHU collaborates with multiple organizations to promote and educate on the work of the AETC program. Since 2018, NAHU has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, recovery, and harm reduction of opioid use disorders and other substance use disorders through the provision of locally designed education and training. Visit the website to submit ATA requests, read case studies, see featured resources, check out upcoming ORN events and trainings, learn about ORN work groups addressing health disparities, and more. So we do value and welcome your feedback on today's webinar. We will include a link to the evaluation towards the end of the session, and it will also be included in the post-webinar email. You will have 2 weeks to complete it. Once the evaluation is closed, unfortunately, we will not be able to reopen it. So we do ask that you complete it if you are looking to provide your feedback and request CME, CNE, social work CE, or certificate of attendance that you completed within that time. If you are requesting CE credit or certificate of attendance, again, you will need to complete the evaluation. To receive contact hours for participating in the continuing education program, you must join the webinar. It must be under your name, so the name that you registered under should reflect the name that you're joining us today. Attend at least 60% of the scheduled presentation and complete and submit the electronic evaluation. You will receive your requested certificate within 3 weeks of submission of the evaluation. So without further ado, I have the great pleasure of introducing our wonderful speaker for today. Dr. Sarah Rosenwald-Mack is an addiction medicine and family medicine physician at the University of California, San Francisco, UCSF. Her clinical research and policy work sits at the intersections of addiction medicine, HIV care, and reproductive health, especially in marginalized populations. So without further ado, I'd like to pass it over to our speaker.
Hi, can everyone hear me okay? Thank you so much for having me. It's really an honor to be here. I'm going to start by sharing my slides, and then we will get started. Okay. As mentioned, my name is Sarah Rosenwald-Mack. I am a family and addiction medicine physician. I work at both UCSF and the San Francisco Department of Public Health in a variety of primary care, addiction medicine, urgent care, street medicine, and hospital settings. It's a pleasure to be here today. I really appreciate folks' contribution to the chat waterfall. I see that people have a really wide variety of experience with injectable buprenorphine, and I will hope to tailor the content to be useful to everyone. But I'll provide my email at the end, and please feel free to reach out with questions or further discussions. I'll leave some time also for questions at the end. Our objectives for today, let me just adjust. There we go. So first I want to discuss contextualize. So let me take a step back. The primary purpose, the meat of this talk, will be to talk about direct-to-inject buprenorphine, which is a new way to start buprenorphine directly with an injection rather than with a sublingual lead-in or test dose. To do that, I'm going to start by contextualizing clinical indications for sublingual versus long-acting injectable buprenorphine. We will then characterize the role of direct-to-inject in starting buprenorphine and talk about why this is exciting and something new that we can offer to our patients who have opioid use disorder. And I'll end by talking about implementation and how to adapt for clinics who are interested, adapting existing direct-to-inject protocols to varied clinical settings. This talk will be about opioid use disorder, but I want to make sure that folks know, because it's important for all of us who work primarily or largely in HIV as well, that there are no clinically significant interactions between buprenorphine and antiretroviral medications. There are some pharmacokinetic interactions, and there are some cases where you will monitor perhaps a little more closely, and I can discuss those later. But overall, you can use buprenorphine for any of your folks with HIV or on PrEP. And that's important to know, because we know that we have lots of people who have HIV and who also have opioid use disorder. In this talk, I'll start by discussing direct-to-inject bup initiation as contextualized within the landscape of injectable buprenorphine generally. I'll then turn to the work that my team has done on evaluating and implementing this method of starting buprenorphine in outpatient settings, clinics, street medicine, shelter health sites, and then I'll end by talking about implementation. So to start, we all know that bup saves lives, and it's a tremendously effective medication. There's approximately a 50% reduction in all-cause mortality compared to no treatment for folks with opioid use disorder who are on buprenorphine. We have had for a long time, the main tool at our disposal has been sublingual buprenorphine. Injectable buprenorphine came on scene, it's been a number of years now, but more recently relative to sublingual buprenorphine. And there's a number of things that I want to highlight in thinking about the landscape of injectable and sublingual buprenorphine. The first is just the sort of nitty-gritty of duration. We know that sublingual buprenorphine is a medication that folks can take 1 to 4 times a day. It needs to be taken at least daily. Most people take it twice a day at least. And the levels decline pretty within hours after taking it, which is why it needs to be taken again fairly soon. Injectable buprenorphine, there are 2 forms. There's a weekly form of the medication and a monthly form of the medication. For simplicity, I'll use brand names, though I generally try to avoid that. But the medication we've had for a long time that folks also refer to as first generation injectable buprenorphine is called Sublocade. That's a monthly injection. And the newer medication that was approved recently that many folks call second generation injectable buprenorphine is called Brixadi, and that comes in both weekly and monthly formulations. When there are studies comparing the efficacy, overdose protection, and retention across these different forms of buprenorphine, studies find different things, and there isn't a huge amount of robust data. In general, the efficacy of preventing return to use is roughly equal for injectable and sublingual buprenorphine. We suspect that injectable buprenorphine potentially provides a little more overdose protection, especially in folks who struggle to take a daily medicine in the same way that we know that our injectable HIV medications provide really robust coverage for folks who struggle to take daily medicines. And the data generally shows that retention is a little bit better on sublingual bup than on injectable bup, though most of these studies are sort of very broad population studies. And in the settings I work primarily in public health settings in which folks are typically on Medicaid or uninsured. Many people are experiencing homelessness. And in those settings, we often see that retention is actually better on injectable buprenorphine, again, for many of the same reasons that injectable HIV medicines and PrEP have advantages in folks taking those medicines. Access and cost are important to talk about. Medicaid generally covers injectable buprenorphine across the country, but there's big barriers to access, both in terms of prior authorization requirements that are instituted in many places, as well as there are just fewer providers who have experience, fewer clinicians who have experience with and are comfortable prescribing injectable buprenorphine, which does mean that it's something that is often less accessible to our patients, especially outside of urban areas. I think in rural areas in particular, it's harder to get access to injectable buprenorphine. Um, but Medicaid does generally cover it. Other insurances can vary. And it's certainly a beneficial and important tool to be able to offer to our patients. The last two things I want to touch on just to frame this general conversation about injectable versus sublingual bupe is dose flexibility and diversion. I'll start by just a brief mention to diversion, which is that there are folks in some settings, for example, in carceral settings, who are particularly concerned about diversion of buprenorphine, and sometimes injectable buprenorphine is preferred for that reason. Um, and then dose flexibility is important to discuss for a couple of reasons. One is that sublingual buprenorphine allows for day-by-day tailoring of your dose. A patient can choose how many buprenorphine tablets or films to take, or you as the clinician or another support staff can advise them about how to change their dose or take it PRN if that's something that's of use to them. There's more day-to-day flexibility. But there is also tremendous flexibility with the long-acting injectable buprenorphine, both because you can give people sublingual buprenorphine on top of injectable if that's appropriate for them based on their tolerance and their need, but also because you can change the dose sort of month to month, which can be helpful. The other part of dose flexibility, though, that I want to highlight is that a profound advantage of injectable buprenorphine, especially the monthly Sublocade, the first generation injectables, is that once somebody is at steady state, which is once they've had like 4 monthly injections, basically, they maintain therapeutic levels of buprenorphine in their body for months. There's a really long tail after the last injection. So this is tremendously helpful if you know that somebody struggles to take this medicine consistently. We don't have the concerns about resistance that we have with the tails for HIV medicines, and we just have the profound advantages of overdose protection, that if people have buprenorphine in their system, they're less likely to die of an overdose. And that is such a tremendous benefit. I'm going to turn now to a little bit of discussion about long-acting injectable buprenorphine pharmacology. The main things that I want to highlight, the main thing that I want to highlight really in this slide is the time to peak. Sublocade has a first peak within 24 hours, and a lot of that first burst of medicine is actually within the first 2 to 3 hours. Brixadi, the weekly medicine that we use for direct-to-inject, peaks at 24 hours after administration. And that's going to be a key point when we talk about why this way of starting buprenorphine works. And then the monthly form of Brixadi peaks at about 6 to 10 hours. You can also see information there on half-life and the time it takes to reach steady state of the medication. This is a more detailed table that will mostly be hopefully helpful for reference afterwards. The main There's three main things that I want to highlight in this table. One is that if a patient is on the first generation, the Sublocade buprenorphine at a 300 milligram dose, the highest dose, and they're at a steady state of that, that's the way they're going to get the highest serum levels of buprenorphine in their body. So for our folks who use, in our clinical experience, a gram of fentanyl a day or more, many of them will benefit from much higher levels of buprenorphine. The highest doses of injectable buprenorphine reach approximately 50 milligrams, equivalent to 50 milligrams sublingual, versus the highly dose of Brixadi, the highest monthly dose equivalent reaches only 18 to 24 milligrams. And so Brixadi also comes in much lower doses, which is profoundly useful for folks who primarily use or used heroin, or who use less consistently, or who use opioid pills and have a lower tolerance. Or for folks whose goal is to reduce but not necessarily stop their use, and they want to use the injection as a form of harm reduction. The other thing I want to highlight is that Sublocade, the older injection that we still use lots, is a little bit more painful and forms a lump under the skin. And Brixadi is much less painful. The pain of Brixadi is closer to the pain of a flu shot, and doesn't form a lump under the skin. What I want to talk about now, I want to take a step back from our discussion of long-acting injectable versus sublingual bupe and really highlight why we're interested in direct-to-inject and what it can do. So we said a few minutes ago that buprenorphine saves lives, and we know that. Methadone also saves lives. These medicines are both tremendously effective. The downside to buprenorphine clinically is that it's hard to start. And the reason it's hard to start is because of the concern for precipitated withdrawal, which our patients all certainly describe to us. But the idea for anyone who's not familiar with the concept is that if you have a full agonist opioid like heroin or fentanyl on the opioid receptors in your body, and you introduce buprenorphine, which is a partial agonist, buprenorphine binds with higher affinity to those receptors than fentanyl or heroin, which means it will kick off the fentanyl or heroin, but it's a partial agonist. And so the amount of opioid, we talk about opioid tone or the amount of opioid agonism effect is lower with buprenorphine than with heroin or fentanyl. So in this graph here, if you imagine an effect, there's no scale on these axes, but on the bottom we have, on the x-axis we have dose, and on the y we have effect. And if you look at the pink line and you imagine that somebody is reaching this much effect when they take heroin and they then take buprenorphine, their receptors are all going to be saturated with this opioid. Buprenorphine is also an opioid, but it's a partial agonist, which means that it has agonist and antagonist activities, doesn't provoke as much opioid effect. And if given when somebody has fentanyl or heroin on their opioid receptors, has the risk of precipitating withdrawal. So this is another slide that details some of the problem with this sort of cute picture in which the full agonist opioid, the orange pentagon, is displaced by these little blue trapezoids. Forgive my lack of geometry knowledge. And that causes effective withdrawal. So there have been, in hospitals, inpatient, there are some creative ways to start buprenorphine, especially immediately post naloxone, Narcan, or their kind of other protocols in the outpatient setting, which is where many of us work. There have traditionally been two ways to start buprenorphine: macrodosing, or a traditional large dose start, or microdosing. Macrodosing, basically, when people mostly used heroin, worked great. If people could wait 12 to 24 hours from the last time they used heroin, you could give them a big dose of bupe, they would immediately feel better. It would take them out of withdrawal. It worked really well. In the fentanyl era, it works much less well. We have found that people typically need to wait actually closer to 48 to 72 hours from the last time they used fentanyl in order to safely be able to start with a large dose of buprenorphine with a low risk of precipitating withdrawal. And we have very few patients who can tolerate the amount of withdrawal that they experience in waiting 2 to 3 days from last use. So in most of my clinical settings, um, macrodose starting is sort of off the table. Times where it still is useful is post naloxone, or in settings where someone has no access to their medicine, for example, their opioid of choice, for example, in carceral settings, there are still some uses for macrodose starts. But what generally happens in San Francisco and sort of across the country when you're trying to start buprenorphine outpatient for folks who use fentanyl is what's called the low dose overlap start, in which folks are given tiny escalating doses of buprenorphine to take over 3 to 7 days. This is really hard. Here are demo packs from one of our local pharmacies, which are this local pharmacy is called CBHS. It's amazing, and they bubble pack these medicines for patients in really sort of phenomenal ways. And I don't know about you, I would really struggle to take a medicine 4 times a day. I'd struggle to take medicines less than that. But taking a small dose of a medicine 3 or 4 times a day, especially for folks who are unstably housed or whose sleep-wake cycles are disrupted by substances they use or any number of other reasons, this way of starting buprenorphine, which for a long time has kind of been the only way we really have outpatient, is very difficult. And our local research shows, by some of my colleagues, shows that actually in San Francisco, less than 30, something like 30% of people who try to start bupe this way actually manage to even complete the 3 to 7 day bupe induction. Which brings us to direct-to-inject, this new way of starting buprenorphine in the outpatient setting. And the profound promise of direct-to-inject is that you can give somebody an injection of buprenorphine, of weekly Brixadi, when they are in mild withdrawal. For those who use COWS scores, this can be a COWS of 4 or more, 6 to 12 hours from last use. And so they don't need to wait nearly as long as for the macrodose, that's 48 to 72 hours. They just need to be able to tolerate a little bit of withdrawal, wait 6 to 12 hours from last use, and then you can safely give them this injection that will help them start buprenorphine. So how does it help them start? This is the reason why. So again, how do you define direct-to-inject buprenorphine? It's the initiation of buprenorphine via Brixadi, the second generation weekly long-acting injectable, without a prior sublingual test dose or transition from prior stability on buprenorphine. The reason it works, so we know, we talked about with a macrodose start, how you can get precipitated withdrawal. And that's because when you give someone buprenorphine, as we discussed, it can kick fentanyl or heroin off the receptors. The reason for that is this gray line in this graph. The x-axis, we have time in hours, and the y-axis, we have bup concentration in nanograms per milliliter. And what you can see in this gray line that represents a dose of 16 milligrams of sublingual buprenorphine, which is a common dose used for macrodose or large dose initiation, you see that you have a rapid peak of the buprenorphine. It usually peaks at about sort of 45 to 90 minutes, and then a rapid decline. On the other hand, this black line represents 24 milligrams of Brixadi, and that of second generation injectable buprenorphine, which rises slowly over the first 8 hours, and then even more slowly until 24 hours where it peaks. And this gradual rise of the injectable buprenorphine mimics the low dose overlap starts, the microdose starts that I described here. But it does it over 24 hours, over a more compressed time, and it automatically titrates itself up in a person's body as the levels accumulate, and therefore doesn't require people to take a medicine 4 times a day. So when I think about direct to inject and I conceptualize it within the framework of starting buprenorphine that I understand, I think of it as essentially an expedited low dose overlap start. Does that make sense? Like people will still have fentanyl in their body when they start taking this injection. But as the fentanyl in their body decreases and the injection increases, they're usually able to transition to buprenorphine relatively smoothly, with most people experience some mild to moderate, but not severe or precipitated withdrawal. The Brixadi, this medicine is a newer medicine for many of us. We've only had access to it for the last year, and many clinics don't have access to it yet. And so I want to just briefly highlight that there are, as mentioned, both the weekly and monthly forms, and they correspond to different sublingual dose equivalents. So if you gave someone a 24 milligram weekly injection, the daily dose that they would be experiencing each day for that week that the medicine covers is about 12 to 16 milligrams of sublingual bup. And you can see here, when you think about the fact that many of our patients who regularly use fentanyl require 32 milligrams of sublingual bup, you can see why maintenance on Brixadi may not be appropriate for many of our folks who use fentanyl and who want to stop using, but it is a tremendously powerful tool in helping people start buprenorphine for the reasons described. I'm going to turn now to a brief review of the data. The first published anything on direct-to-inject buprenorphine came out a year ago, almost exactly, which was this from the ED Innovations study by Gail D'Onofrio and her colleagues. And this is a study of extended release, 7-day injectable buprenorphine for patients with minimal to mild opioid withdrawal. So this was a study in patients were not randomized. They were in mild withdrawal. There were 100 of them. They were all given 24 milligrams of injectable buprenorphine and monitored for 4 hours. And they were characterized as having had precipitated or very severe withdrawal if they had a significant increase in their COWS score, or which is a objective measurement of opioid withdrawal. And that likelihood of withdrawal was higher for folks who had a lower COWS score prior to injecting. I want to highlight this point because it's a little complicated, but it's really important. The idea basically is that if you are in some withdrawal prior to this injection, withdrawal reflects that some of the fentanyl has left your opioid receptors. And that means that when you give people bup can attach to those receptors and they're more likely to feel better rather than the buprenorphine displacing the fentanyl on the receptors, which is what causes what we call precipitated withdrawal. So the idea here is that they found, which is expected or not unexpected, that folks who were experiencing a little bit more withdrawal had a lower rate of precipitated withdrawal, a little more withdrawal prior to injection, had a lower rate of precipitated withdrawal after injection. That was the only data we had a year ago. We in the San Francisco Department of Public Health and at UCSF wanted to be able to offer this as a tool to help our patients start buprenorphine, and there was no outpatient data, and we didn't know how to identify good candidates for this, how to minimize patients' risk of withdrawal, how do we counsel patients, when can we give them the next dose of buprenorphine. And for that reason, we conducted a study of all of the direct-to-inject instances that had happened in outpatient settings in the Department of Public Health over the first 8 months that we had access to this medicine, looking at withdrawal and retention on buprenorphine. This was a very small retrospective like case series because this is a relatively new tool. We had 21 unique patients and 22 direct to inject initiation attempts. But the results were really promising. So almost 90% of people experienced mild or moderate withdrawal. Very few experienced severe withdrawal. Some experienced none at all. And almost 80% of people were retained on buprenorphine 7 and 30 days later. So they got an additional injection or additional sublingual buprenorphine later. I want to really highlight this is the thing that has been one of the most exciting for us clinically, and one of the great promises of direct to inject buprenorphine, especially for folks using fentanyl, is that our data shows that the other main way we have to start fentanyl outpatient, these microdose or low dose overlap starts, just isn't that effective at getting people on buprenorphine. I talked about how the local data we have shows that only something like 30% of people can even complete the 3 or 7 day protocol. The percentage of people who are on buprenorphine a month later after trying to start that way is like 20%, which is so different from 80%. And it has been amazing. I'm so excited about this work because it has been amazing to see the retention that we have on buprenorphine and the success that we have starting people this way. And we've had patients at multiple of the clinics that I work at now. We have patients come to us and say, my friend started buprenorphine with an injection. It went really well for them. I want to do the same thing. And to have patients optimistic about and seeking a treatment and telling their friends about the effectiveness of a treatment is so, so exciting at this moment. So our conclusions, I've highlighted most of them, but the key ones were that this was generally very well tolerated, but most people did have some mild to moderate withdrawal symptoms. Our qualitative research is ongoing, but basically many people characterize that as when asked about their withdrawal experience, say something like, yeah, I felt a bit bad for the first 24 hours, but I was able to sleep through most of it. Or, yeah, it didn't feel great. I felt kind of like I had the flu, but it was much better than normal withdrawal or unmedicated withdrawal. Um, Really excellent retention, as I talked about. And there is some evidence that some recent exposure to buprenorphine may help ease this process, which I can talk about later if we have time. But basically, folks who had some of our patients had received like a half, basically, they've taken a day or two of a microdose starter pack, which means they received like a half milligram of sublingual bupe a couple times in the few days preceding this injection. And those folks tended to do better. And by that, I mean, had less likelihood of notable withdrawal after the injection. Um, the Before I turn to implementation, actually, the other conclusion that I want to share, or the other thing that I want to share about when I talk with patients about this experience and about what we've learned so far, and we now have numbers in the sort of hundreds of patients who have been doing this rather than these smaller numbers that we had at first, is that I tell patients that many people feel a little rough for the first 24 hours. Then at 24 hours, you'll have a good level of buprenorphine in your body. You should feel pretty good. And at that point, you can safely take a lot more buprenorphine. You can have another injection or take more sublingual buprenorphine, and and then you'll feel much better. So it really is like there's a slightly rocky 24 hours, and then you will be fine. And that has been a helpful framework that folks have found helpful and also accurate to their experience. Um, this brings me to another point that I want to make before I move on to implementation, which is the last question here that we had that motivated some of our research, which is when can you give more buprenorphine after giving an injectable dose of DTI, of this direct to inject medicine? And this is the other really big takeaway that we have found that we're so excited about, which is that you can safely give another injection of buprenorphine the next day, including a dose of a monthly injection. As long as somebody, to explain that, I'm going to turn back to this slide. As long as somebody has received a 16, 24, or 32 milligram dose of injectable buprenorphine as their direct to inject starter dose, and people choose these doses based on patients' suspected opioid needs, they will, 24 hours later, have the equivalent of this much sublingual bupe in their body because this medicine peaks at 24 hours. And that means anyone who has this equivalent of sublingual bupe in their body can safely receive, for example, 300 milligrams of Sublocade or another dose of a monthly injection. And this is one of the most promising uses of direct to inject, I think. It's the ability to rapidly start someone on monthly injectable buprenorphine. Someone comes to my clinic, I give them the direct to inject dose on Monday. On Tuesday, I can give them a monthly injection, and now they're covered for a month. And that has been tremendous for so many of our patients. I'm going to I'll save plenty of time for questions. This is a new and exciting topic, and I imagine there will be questions. But I want to talk before that a little bit about implementation for um, folks who are in clinical settings interested in implementing this. We have a lot of tools available that we would love to share, and I'll share my email address again if helpful. One is that we developed for the San Francisco Department of Public Health that is now publicly available, a direct-to-inject buprenorphine guideline protocol that is also linked. This QR code links to a box folder that has the most updated version of that protocol, which is why I'm sharing the box link rather than the URL for this, though I can share that as well. It's the same thing. Um, and that's like a 7 or 8 page document that provides a ton of resources about how to do this. If your clinic can do injectable bupe, you can do direct to inject. And we talk about like how to do that. And that includes both logistical and clinical considerations. The overall protocol that we've developed and that we've been using across San Francisco Department of Public Health and UCSF sites it has these 5 steps. Starts by identifying appropriate patients. So patients in mild opioid withdrawal with a COWS score of at least 4. COWS is the clinical opioid withdrawal severity, I think, scale. It's easily sort of accessible online. If folks have waited 6 to 12 hours from the last time they used fentanyl or heroin, and if they don't have recent high-dose methadone exposure, which we usually define as within the last week. The second step is determining and giving the dose of long-acting injectable buprenorphine of the Brixadi. And there's a lot of guidance in this document about how to determine the dose, but mostly it comes down to an assessment of a patient's suspected opioid tolerance, as well as your concern for their risk of worsened withdrawal with an injectable buprenorphine dose. We then, for all patients, prescribe opioid withdrawal adjuncts. So this is ondansetron, clonidine, hydroxyzine, loperamide, Tylenol, ibuprofen. We prescribe everyone supplemental sublingual buprenorphine to start 24 hours after the injection. And it's very important. We counsel patients not to start it before it's been 24 hours since the injection because the buprenorphine levels aren't typically high enough in their body at that point and they would risk precipitating withdrawal. And then finally, the last step is providing counseling, which I've talked a little bit about, and making a follow-up plan for the next dose. We emphasize to patients that, once you're on buprenorphine, it's really easy to adjust, but starting it can be the hard part. And so we really want to make sure now that we're starting you on it, that you get your next dose of buprenorphine if you want to stay on it within the next week so that you don't have to restart. We now standardly recommend that someone come back the next day or 2 or 3 days later for a monthly injection if we are confident enough in their opioid tolerance to have a good sense of what monthly injection they're likely to need. And there's more information about that in the protocol as well, but they can really come sort of for up to a week to get their next dose. The resources also include patient-facing handouts about what to expect to feel and include suggested electronic medical record documentation if that is helpful. I'm gonna end with a couple of takeaways about direct-to-inject buprenorphine and its implementation. The first of which is that direct-to-inject in our settings has received tremendously positive patient feedback. There's much better retention than any other way we have of starting buprenorphine, and you can start monthly bupe injections the next day. The only contraindications to direct-to-inject buprenorphine, honestly, are unwilling, not open to an injection, not open to a needle is of course a reason you wouldn't give this to somebody. And we tend not to recommend it as often in folks who cannot wait 6 to 12 hours from last use, folks who just use constantly and can't wait 6 hours. Though we now have new protocols that we have been piloting for folks who can't wait anytime and have had success with those as well. And I can talk about those later. And then we talked a little bit before about some of the benefits of long-acting injectable buprenorphine, the ability to stabilize on monthly injections and decreased risk of overdose and death. One thing that is crucial where possible is same-day access to this medicine. Because when you have someone who comes to you and says, I want to start buprenorphine, you want to be able to start it for them that day. And in some of the settings in which we work, you absolutely can, and we do have same-day access to the medication, either because there's a pharmacy on site or because we can store it in a Pyxis. And in other settings, we don't, and we have to order it from a pharmacy for delivery the next day or for courier pickup the next day, and we have to ask patients to come back. And that can be a real barrier. to access. And that highlights also the sort of complication of pharmacy coordination and delivery. But yeah, there are tremendous opportunities and promise to this new way of starting buprenorphine. I want to also share the our slide on the National Clinician Consultation Center, which I hope many folks are familiar with, but is a clinician warm line hosted out of UCSF. It's a free, completely free telephone resource. We answer questions about HIV, about Hep C, about PrEP, about PEP, and also about substance use. And so if you ever have clinical questions and want to phone an expert who will answer the phone then or call you back within a few hours typically, this is a tremendous resource that I want to make sure everyone is aware of. These are my references. This is my email address. Please reach out with questions. And I'm gonna stop here and stop for questions. That was a bit of a whirlwind tour.
No, thank you so much. That was extremely informative. We appreciate that. I do see that there are two questions. In the meantime, just to let people know, you can please, if you have a question, you can add it to the QA or you can raise your virtual hand. Starting with the first question, clients have a lot of questions about tapering of oral Suboxone and with Sublocade. Any recommendations?
Yes, that's an excellent question. So for many folks who are on oral buprenorphine, Sublocade or Brixadi, these injectables can be really effective medicines for taper. Sublocade, because it has a longer tail, the medication levels decline more slowly in the body over a longer time, is actually often the most effective way to taper off. There are no established guidelines about the best way to do that, and I would certainly recommend tailoring to your patient's experience. But for example, if you had a patient who is stable on 32 milligrams of daily buprenorphine or some other dose, like a high dose of daily buprenorphine, you could give them a monthly Sublocade injection. And then you could just follow them closely after that first month, not give them a subsequent injection, and see how they feel as that medication continues to decline in their body over the following few months. They could take additional small doses of sublingual on top of that declining injectable level if it feels like it's declining too rapidly. You could supplement with a weekly lower dose injection. You can stack injections, like if you gave somebody Sublocade 300 and at the end of the month, that's when they'd be due for their next injection. They still have a large amount of this medicine in their body. And then over the following week, they're fine, and the next week they're fine, and then they're starting to feel a little more withdrawal and like this taper is too quick. You could at that point give them a monthly injection of a lower dose of Brixadi that will sort of add on to the waning Sublocade and continue a taper. So there's a lot of flexibility, and it's really going to depend on your patient's experience. But yes, these medicines are profoundly useful for tapering because you can taper much more slowly and smoothly than you can with sublingual buprenorphine, both because the doses can be more transitional versus like with sublingual where it's hard to have a dose that's more precise than sort of 1 milligram differences, based on our ability to kind of cut the films or the tablets, but also because the injectable buprenorphine provides 24-hour coverage that is consistent throughout those 24 hours, which can be profoundly useful in a tapering process versus the more intermittent increase and decrease that you get with sublingual dosing.
Do you experience issues with insurance, Medicaid coverage for the quick stepping from weekly to monthly dosing, or with duly prescribing an LAI with supplemental oral bupe?
That's an excellent question, and this is going to vary but across states and in different settings. We have had no problem billing for weekly day one and monthly the next day. That has not been an issue for us. We have also not had an issue with prescribing sublingual bupe on top of injectable bupe for folks who are not on. So a lot of our people who are on Sublocade 300 milligrams actually stay on Sublocade 300 milligrams. I think the traditional recommendation is that they get 300 for the first 1 or 2 loading doses, and then 100 of Sublocade for every subsequent dose. Across the country, there are loads of patients who stay on 300 milligrams of Sublocade every month. That's fine. That works really well. Once those patients have had 4 injections and reach a sort of steady state of the medicine, it is not typically clinically necessary to continue to give them sublingual buprenorphine, and we have had insurance difficulty covering it beyond that, which feels reasonable. But otherwise, we have not had difficulty with getting coverage for the overlap injectable and sublingual.
And is the monthly injection covered the day after receiving the DTI weekly injection?
We have had it covered with no problem the day after receiving the weekly injection. It actually has never been a problem with Medicaid. There is one of our and actually, it hasn't been a problem at any commercial pharmacies. Our hospital outpatient pharmacy and our specialty mental health pharmacy, both of whom are very, very involved in some of the logistics of buprenorphine, wanted us to point to a protocol where we had this like clinically indicated. And once there was a protocol that we could refer them to, they were very happy to cover it. But we actually haven't had any issue with Walgreens or CVS or pharmacies like that covering this. I will say, some folks, if folks have done a deep dive in this space, may be familiar with a new protocol that's come out from Seattle relatively recently, in which they do an injectable dose on day one, a weekly injection on day one of 8 mg, another weekly injection on day two, typically of 16 mg, and then a monthly injection on day three. This is a high touch, high cost protocol, but it actually is very effective for folks who can't stop using fentanyl at all because it does a much slower introduction of buprenorphine into the system. There is sometimes pharmacy issue covering that.
So just to clarify, can we use both the sublingual and injectable?
Yes, absolutely. You can use both sublingual and injectable, and it is often appropriate to use both. I will also say, if I have a patient come to me and they say they use a gram of fentanyl every day, in my experience and based on what fentanyl looks like in San Francisco and in the Bay Area, they are going to be someone appropriate for 300 milligrams of Sublocade every month. That's going to be an appropriate dose for them, or 32 milligrams of sublingual. If they say less than that, if they say, I use about $10 a day, which sometimes is about a quarter gram here, though that changes a lot, or I use mostly heroin, or I don't use every day, or if I have another reason to not be as sure of what their actual tolerance is and they do want a monthly injection, I will very often start them on a lower dose of monthly injection and then give them lots of sublingual to supplement. So, for example, somebody tells me, I use fentanyl every day. I use maybe about a half gram a day or a quarter gram a day. Those people we know from our clinical experience are going to need at least 12 milligrams of sublingual bupe, probably at least 18 to 24 milligrams of sublingual bupe a day. But if I'm really unsure and they use like a quarter gram a day, what I might do is give them a weekly injection. And then the next day, give them a monthly injection, for example, of 96 milligrams monthly Brixadi. So then they're going to be covered with that monthly injection with the equivalent of 12 to 16 milligrams of sublingual a day. And then I'll give them a bunch of sublingual films. And I'll say, take what you need, like take, 4 to 8 milligrams a couple times a day, every couple hours, up to what is sort of the equivalent of a total of 32 milligrams daily total dose, and see how you feel, see what you're finding that you need. Unlike methadone, there's no risk of, there's much less risk of sedation or overdose or apnea or anything like that with more buprenorphine. So patients can experiment with it to see how much they need. And then once I know that, I can make an informed decision about what their actual buprenorphine need is, what their actual opioid tolerance is, and what their next dose should be. So all of this as a long answer to say, you can do monthly injections before you know what someone's tolerance is, as long as you lowball the dose. And this is a very common clinical scenario in which I will give someone simultaneously both an injection and supplemental sublingual buprenorphine.
And can you outline your approach for patients who cannot wait 6 hours?
Yes. Great question. So we have a couple of options for folks who cannot wait 6 hours. This is all, and I should also say as a caveat, this is all like wildly off-label. It is clinically appropriate and we are doing what we can, but the on-label indication for weekly Brixadi, this weekly injection, is you give someone a 4 milligram sublingual test dose, and if it's tolerated, you give them a weekly injection. That is almost never clinically appropriate, I would say, because often if I'm confident that somebody will not precipitate withdrawal, which is the point of the test dose at 4 milligrams, I'm rarely do I feel confident of that. And if I do, it's because it's been 72 hours since they last used and they're in horrible withdrawal. And actually, I'm going to give them 8 to 16 milligrams. So direct to inject and all of these things are off label and recommended by clinical guidelines, appropriate and covered by insurance. I should give that caveat. For folks who cannot wait any time between, like without using, there are two different things that we have been clinically experimenting with that we have found useful. One is the Seattle protocol, which folks from institutions in Seattle have been talking about in various settings, and they're doing really amazing and inspiring work in helping people start buprenorphine. They often have success with a 3 injection protocol that I described, where they get a weekly injection of 8 milligrams on day one, a second weekly injection that I think is of 16 milligrams, though I'm not remembering for sure, on day two, and then a monthly injection on day three. And we've been adapting that protocol in our settings and for folks who cannot stop using at all. And because of the slower introduction of buprenorphine, we have found that effective for some folks. Most people still experience some amount of mild to moderate withdrawal, but many folks can tolerate that in a way that if they just got the weekly injection of, say, 24 milligrams or 32 milligrams, when they haven't been able to stop using for 6 hours, they might be much more likely to go into precipitated withdrawal. Um, that is, again, work that comes out of this group in Seattle that's really amazing. Lots of kudos to them for the incredible work they're doing in this area. Another protocol that we've been experimenting with in some of our clinics that one of my colleagues, Dr. Abs, has begun rolling out is a patch protocol, where for folks who have, so the Butrans patch, or the buprenorphine patch, is approved for chronic pain and also for the overlap chronic pain and opioid use disorder diagnosis. And so if you have a patient who has chronic pain and opioid use disorder, what she's been doing is she's been experimenting with a couple days of buprenorphine patches prior to an injection and not requiring people to stop using in that process. And the way that she's been doing patches and building up patches over a couple of days, with a couple of patches placed on day one and then a couple more on day 2 or 3, and then giving the injection, has enabled people to have a relatively smooth start as well. So these are, even more kind of off-label avant-garde methods of starting buprenorphine, even beyond that sort of more what is becoming more typical direct-to-inject starts. But we have found some success with those. Really good question.
Yeah, you mentioned protocols, so someone did want to know what are the bupe protocols that the warm line is using?
That's a great question. I don't know the answer to that offhand. I have only occasionally taken substance use calls on the warm line, and in those cases, I think generally the clinicians who take those calls are using kind of clinical judgment and their addiction medicine experience and referring to protocols from various settings that they work in. I don't know if there are specific protocols to the warm line, but I can try to find that out and send that answer back to folks, because that would be good to know.
And so I'm gonna kind of combine two questions. So one question is, may the methadone clients switch to the injectable buprenorphine, but also have you transitioned anyone from methadone to DTI with success?
Yes. Great questions. So one of my other areas of clinical interest is methadone to buprenorphine transitions. I also work at an opioid treatment program at an OTP at San Francisco General Hospital, and called Ward 93. And there we have a bunch of different ways that we think about trying to transition people from methadone to buprenorphine. The We do not have a lot of clinical experience. Our N is in the like single digits of this right now, of the methadone to buprenorphine via direct to inject. We have plenty of experience with methadone to buprenorphine via low dose overlap starts, which I can talk more about in another setting. But so speaking from very limited experience, we have had success transitioning people to buprenorphine if it's been 7 days from their last methadone. So if somebody was on, kind of regardless of dose, so if somebody was on 120 of methadone regularly, their last day of it was 7 days ago, they can wait 7 days. We can start them with direct to inject buprenorphine. Um, we have had more success doing that in the inpatient setting, where we've been able to give people oxycodone or hydromorphone, short-acting full agonist opioids that keep them from going into withdrawal, but also don't provide the kind of days-long tail that makes starting buprenorphine more difficult. So the inpatient setting is a particularly fruitful place to do this. In the outpatient setting, I have done this with folks who were on methadone, who last took their methadone a week or two ago, who have since returned to fentanyl use. And I am then comfortable starting them on direct to inject once it's been 6 hours since their last fentanyl use and 7 days from their last sustained steady state methadone. We also have a lot of patients who, not a lot, we have some patients who take non-prescribed methadone on the street that they get from other people. And that can be really hard because you don't know the amount that they're getting, and they often don't know the amount that they're getting, even if they say they do, because it's hard to know how concentrated the liquid methadone is. In fact, it's impossible to know. And so But for example, I have had a patient who I started on direct to inject who had taken methadone from someone on the street like 4 days ago one time and had last used fentanyl like 6 hours ago. And I felt comfortable starting him, even though it was less than 72 hours from less than 7 days from last methadone, because that had been like a one-off dose and he wasn't at steady state. And we know that methadone at steady state really stays in the body for a long time. That was a long answer to a very complicated but good question.
Uh, is there any dropout case of injectable bupe? If so, what were the common causes?
Any what, sorry?
I guess someone stopping injectable, so a dropout case of someone no longer wanting to use it.
Oh, commonly. I think the question of this is a really interesting question because when we think about initiation methods, the question of buprenorphine initiation and buprenorphine retention are related but distinct. So um, many patients who start sublingual bupe don't continue it. Many patients who start injectable bupe don't continue it. These questions of retention are really complicated, and there's a lot of reasons why people don't necessarily continue these medicines for a lot of the same reasons that people don't continue PrEP, for example, or any other medicine that once started, you kind of hope they'll just kind of continue on an ongoing basis for many months to years, and yet many folks choose not to or aren't able to for whatever reason. Um, when thinking about reasons that are specific to the injections, most people tolerate injections really well. So I would say there are definitely people who don't want the injection because they're scared of an injection. But most people who've had one injection are totally fine getting another injection. I very rarely had someone who's had an injection and then said, "Oh my God, that was terrible. I could never do that again." Because they're relatively well tolerated and not extremely painful. Especially Brixadi it's like a flu shot. It's not fun, but it's not very painful. Um, the so, are there reasons for dropout from injectable buprenorphine that are distinct from dropout from buprenorphine generally? Probably, but I don't have the data about that or to that sort of immediately at hand.
Do you have additional guidance for introducing LAI bupe for clients who are at present opiate naive, specifically clients who are incarcerated, sober due to controlled environment, but experiencing high cravings and at risk of using illicit substances inside NOD risk?
Yeah, such a good question. We are right now in some of the jails in San Francisco or in the Bay Area piloting direct to inject as a way to start buprenorphine. The this question differs depending on when someone last used opioids. If you have a patient in jail who last used fentanyl, a day ago or a week ago or something like that, you can be and they've been using it persistently, you can be relatively confident in that they haven't had a decreased opioid tolerance, and they are also sort of, you know, newly abstaining from opioids because they're in a carceral setting where they don't have access or they don't have reliable access to opioids. We all know that people do sometimes have access to opioids in carceral settings. But and in that case, it's pretty straightforward, and it's really honestly the same as how you would counsel someone to start buprenorphine if they were not in a carceral setting. It becomes a little more complicated, though it's an incredibly useful tool for someone who, say, is in prison and hasn't used to use a gram of fentanyl every day, has been in prison for the last 2 months, has not used any fentanyl in the last 2 months, like went through really bad withdrawal, like didn't really get any bupe, made it through. It's now been 2 months since they've used anything at all. They're having bad cravings and some withdrawal. They want to be on buprenorphine. It's a really good idea for them to be on buprenorphine. But you're going to be a little less sure of their tolerance if it's been more time because people's tolerance naturally decreases with time. Buprenorphine is very safe, but those are the patients for whom you would want to start lowballing a dose. If somebody tells you that they used a gram of fentanyl a day 3 months ago, maybe I'd start with one of these with 96 or 128 of Brixadi, and see how they do and give them supplemental sublingual. But if it's been a while since they've used, there's no risk of precipitating withdrawal with starting an injection. And so in that way, it's a much smoother, that process itself is smooth. It's just the estimation of tolerance that can be a little more complicated.
Have you seen an increase in fatal overdoses in individuals on the injection who still use or lapse?
No, we've seen a decrease. For folks who are on the injection who still use, the injection is tremendously protective against um, overdose because um, the once you have a basically the more buprenorphine you have in your body, the buprenorphine binds to the receptors and prevents fentanyl from binding and protects you from overdose. There are, nanogram per milliliter levels above which you are much more protected from overdose. For example, if somebody is on a monthly injection of 128 milligrams of Brixadi or 100 or 300 of Sublocade, I can be pretty confident that they're very protected. Not 100%, but very protected from overdose if they continue to use. But buprenorphine is protective. It's not, there's no additive risk. It's only protective for people who are continuing to use. And for folks who are continuing to use, many of them, those folks would struggle with taking sublingual buprenorphine, both because it's harder to take a daily medicine and because um, in order to have buprenorphine stay in your system and to not precipitate withdrawal when you restart it, there needs to be some amount of bupe in your system for all the reasons that we discussed. And injectable bupe kind of provides a background baseline of buprenorphine that even if people use fentanyl or something else on top of it, they continue to be protected from overdose and they don't have to restart and they don't have to remember to take the medicine every day. So yeah, tremendously protective.
Now, our last question, I think, you've kind of mentioned, but the question is, are clients interested in the injectable bupe solely because of the timeline factor or for other reasons?
There are a lot of reasons why folks are interested in injectable bupe. And honestly, like I also work in HIV care, and a lot of the reasons are similar to why folks want injectable cab or injectable Cabril or lenacapavir or whatever. And it's in part because it's just a lot easier to get an injection once a month than it is to remember to take a medicine multiple times a day. So convenience and ease is a huge part of it. There are a lot of people for whom, the oral buprenorphine, it's sublingual. It's or like you taste it, and the taste is for many people fine, and for many people kind of unpleasant, and it can cause some nausea. And so there are lots of folks for whom actually the big draw of an injection is they don't have to taste the buprenorphine. There are, I will say, one profound advantage of sublingual bupe for folks for whom the process of putting something in their mouth, of ingesting a substance when they have a craving is a behavioral sort of reinforcing loop. That can be really a reason to use sublingual bupe for some people where they're like, I want to be able to take something when I feel something, not just have a background medicine on board. Other reasons people like injectable bupe, the overdose protection is one of the biggest ones that my patients say. And just in addition to it being hard to take sublingual abuse, many of my folks are unhoused or unstably housed, and it's just really hard to keep track of medicines, to have medicines with you, to not have your stuff stolen, to not have to worry, to have to go to the pharmacy to get the refills. Do you have your ID? How are you going to get the medicine? Whereas the injectable buprenorphine is not picked up by the patient, it's picked up by a pharmacist or delivered or picked up by a clinician. And so the patient just has to get themselves to clinic within some number of weeks of when they're due, and then someone gives them a medicine. And so that they don't have to wait in line at the pharmacy. They don't have to find their ID. They don't have to not lose their medicine or have it stolen. So logistics and convenience are a big draw for many folks.
Fantastic. Well, once again, thank you so much. We really appreciate your time and your expertise. You were getting some high praises in the chat, so you have time to kind of scroll through there. Some really great feedback in there as well. So as a reminder, we do ask that you complete the survey again to provide your feedback, but also if you're requesting the CME, CNE, social work CE, or just a certificate attendance, you will have 2 weeks to complete it. We also hope that you will join us for our next session, which will be on Friday, August 1st, and that is tackling stigma and providing quality care around substance use among older adults with HIV with Dr. Sid Bury. So thank you all once again for your time, and we look forward to your participation in future sessions. Thank you again, Dr. Rosenwald Mack. Thank you so much.
Really my pleasure. And please, low threshold, email me anytime. I'm super excited to talk about direct to inject, all things injectable bupe, and actually also methadone to bupe transitions. So reach out. I would love to chat. I would love to learn from the amazing work that everyone else is doing in this field as well. So thank you all so much.